fetal medicine specialist. I'm also the director of the ultrasound unit here in Brooklyn Methodist Hospital for pregnancy and non-pregnancy. So I do gynecologic and obstetric ultrasound. And I do have a lot of experience with pregnancy and high risk pregnancy in minority populations and non-minority populations, and we all know that there is unfortunately a large gap in morbidity and mortality amongst minority populations. So that will be the focus of my talk, and of course I will address ways that we can improve and things that we are already doing here, not only in Brooklyn, but in other parts of New York specifically. So, and feel free to ask questions too. Okay, so just to start here. All right, I'll talk briefly about some maternal mortality morbidity statistics. I'll look a little bit at the rest of the world compared to the US, discuss some racial gaps in the US, and how we can address those gaps across the pregnancy from multiple timelines: preconception or before pregnancy, during pregnancy, before delivery, delivering itself, and postpartum. And then a little bit, I'll have Lauren talk a little bit about what our resources here are at Brooklyn Methodist. All right, so unfortunately, approximately 700 women die every year in the US as a result of a pregnancy or pregnancy-related complication, which is a shocking statistic. And deaths have been increasing since 2000. So even with our modern advances and treatments and monitoring, we're still not doing a good job, unfortunately. We have higher rates than many other countries, including developed countries, which is really disappointing. Compared to the rest of the world, this is, I think, a nice graphic here. So on the left, you see countries like New Zealand and Norway and the Netherlands and Germany. And then as we get towards the right, we see UK, Canada, France, and then that orange bar is the US. And this is the amount of deaths per 100,000 within 42 days of a pregnancy. So this is more than double the rate of most other high-income countries. So that's really, really disappointing. This is just a schematic looking at what are the cause of deaths, maternal deaths globally. We see that indirect causes of pregnancy is a good chunk. That's the light blue chunk. But the bigger chunks also are hemorrhage. That's the purple chunk. Hypertension, which is the dark red chunk. Sepsis, which is the red chunk. And there's other complications of abortion and unsafe pregnancy care. So these are basically what we're addressing, not only, but primarily in our hospital systems every day, in the antepartum unit, in the outpatient offices, pre-delivery, post-delivery. These are the main things that we're looking at. Pre-existing conditions, which can cause an increased risk of complications, hemorrhage, hypertension, and other indirect causes of death. In the US, the rates of maternal death, like I said, have increased. So you can see in 2019, it was 754 rate per year per 100,000 patients or pregnant women. That increased into 2020 and 2021, it was even greater. So that's overall 32.9 deaths per 100,000 live births. And looking at race specifically, so for non-Hispanic Black women, it was 69.9 deaths per 100,000 live births. That's 2.6 times the rate for non-Hispanic white women, which is crazy. Non-Hispanic Black women are 3 to 4 times more likely to die from a pregnancy-related cause than non-Hispanic white women. And if you look at specifically the age over 40, complication rates go up in that age group across all races, but specifically the death rate per 100,000 live births for non-Hispanic Black women over age 40 was almost 240 per 100,000 live births. So this is an especially high-risk population. These are just another graphical. I like to see this represented with colors and bar graph form. So that second column of bars is a non-Hispanic Black population, and this is going year by year. So this is 2018, 2019, 2020, and it really jumps in 2021. This is compared to like all of our women are doing worse and worse, unfortunately. This is the non-Hispanic white group, this is Hispanic group on the far right. So these also are increasing, but the most increase and the most sharp peak is in the non-Hispanic Black group of women. And this is just over looking at all races, but in age groups. So you can see 40 and over, we really have an especially high risk population of women, which is a lot of the women that I take care of and that we are taking care of here at Brooklyn Methodist and in New York Presbyterian, but specifically at Brooklyn Methodist. And when do most maternal deaths occur? About 1/3 of US pregnancy-related deaths occur during pregnancy. 17% occur on the day of delivery. So that's almost, a fifth. And more than half occur after delivery or postpartum. So this is a really especially high risk time period and where we really are trying to focus our improvements in care. This is pretty shocking. So addressing the racial gap. So nearly half of severe maternal morbidity events and maternal deaths are considered preventable. So there's things that we can do. We need to increase the quality of our maternal care, which is what we have been doing here at Brooklyn Methodist. So I included this. This is like a conceptual model that I thought was very well put together, because attacking this obviously is not a one-way street. We have to go through multiple different ways of looking at this issue of increased maternal morbidity and mortality in minority groups. So there are social, environmental, biologic, genetic, behavioral, and healthcare factors that are important. So this whole green circle here on the right shows the circle that I'm going to be addressing: preconception care, antenatal care, delivery, and postpartum care. So at each portion of the circle, each point in pregnancy, we should look at all these factors to address needs of our patients, specifically in minority groups. So these could, like I said, patient factors, community and neighborhood factors. So looking at our Brooklyn community and our neighborhood of the patients and where they're living and working and getting their medical care. Looking at the provider factors from an OBGYN, an MFM provider standpoint, our knowledge, our experience, our cultural competence, our communication, and also systemic factors like involving the hospital itself, transportation for care, structural racism, and policy level things that we should look at and address as much as we can. And all of these levels can ultimately, if we improve things at each level and in each portion in pregnancy, that will, and has been shown to in many studies, improve our rates of morbidity and mortality. So this is an important slide looking at our own patients. This is looking at outpatient visits. So not so much delivering in the hospital, but this does reflect essentially like the people that are seeking prenatal care in our hospital, in our outpatient clinic setting, and at our ultrasound unit, which is where I'm the director of the ultrasound unit, are reflective of our delivering patients and the patients that are receiving GYN care as well. So as you can see on the far left, the majority, or not a majority, but a good chunk of our patients, almost 20,000 visits per year, are Black. And then white is the next most common racial group. Then we see a combination and Hispanic and Asian, etc. So, but this is like important to recognize because this is the highest group to have increased maternal and morbidity and mortality in pregnancy and around pregnancy. So let's talk a little bit about the timelines and different portions of pregnancy itself. So preconception care. This is super important to help address maternal mortality related to pregnancy-related deaths. We need to address before pregnancy, before someone even thinks about pregnancy, ideally, we should address obesity, hypertension, diabetes, chronic illnesses, congenital heart defects, anything where the patient maybe has not even been diagnosed appropriately or getting treated appropriately. All these things should be addressed before pregnancy. Racial and ethnic minorities have an increased rate of these issues at baseline. This often leads to an increased risk of adverse outcomes for a pregnancy. So this slide's addressing not only the OBGYNs, but really the medical providers, the internal medicine physicians, the endocrinologists, the cardiologists that are seeing patients that are women and are of reproductive age, because many pregnancies, as I'll address right now, are unintended. And maybe a patient says, okay, I might want to get pregnant eventually, but not right now. And then boom, they're pregnant. So having, the ability to kind of address these issues before even they think about being pregnant is super, super important and can really help decrease the mortality rate. So we've been doing a lot of Brooklyn Methodist to encourage discussion about contraception, which is what I was showing on that picture on the bottom right, and to increase communication between OBGYN providers and medicine specialists, nephrologists, hematologists, cardiologists, endocrinologists. Like maternal fetal medicine physicians are a special kind of gateway, that can talk to all the specialties and address concerns for a pregnancy, but it's obviously not limited just to MFMs. We have plenty of OBGYNs and PAs, nurse practitioners, and midwives who are increasingly addressing these concerns when they see patients in a preconception time period. So this is just some statistics supporting that. So reducing the severity of chronic conditions before pregnancy helps decrease the risk of outcomes like preterm birth, miscarriage, stillbirth. Socioeconomic status directly and indirectly influences three major determinants of health: healthcare access, environmental exposure, and health behaviors. So addressing those issues, specifically in those with a lower socioeconomic status, really is paramount in improving the control of medical disorders prior to a pregnancy. So taking action, we're considering and we'll be putting into action some group prenatal methods and group prenatal counseling methods. We have doulas in the in the outpatient settings discussing care with patients after they're seen by their doctors, their providers, to kind of reinforce recommendations and help people get the medical care that they need. But, I think not only us at Brooklyn Methodist, but in general, obstetric care is trying to really think outside the box a little bit more to improve the access to care for patients that are pregnant or considering pregnancy. And that also includes some expansion of Medicaid, which is a little bit harder for me to address in this brief talk now, but that also would help with these addressing these problems. Community-based strategies are also important to complement traditional medical care for minority populations. For example, I included a picture from our breastfeeding, what was that, the baby shower that we did in the community that I was a part of one of the sessions, and we see several of our practitioners and doulas and midwives here in this picture, basically showing our face to the community, being involved in community events, allowing patients to learn more about what we offer at Brooklyn Methodist, lactation support, genetic counseling, just medical care in general. I think this is really important and something that we're really doing a good job of here. Okay, so just in general, we are working towards having a judgment-free, non-coercive contraception counseling for patients who may have some medical issues and who need some optimization prior to pregnancy. And we're doing a little better with screening for these issues prior to pregnancy, and then providing increased access to the medical providers I mentioned before. Okay, moving on to antepartum care or care during pregnancy. So we obviously need prenatal care to keep track of issues during pregnancy and to help manage them as they come up. Screening and management of issues in pregnancy goes a long way to prevent and decrease the risk of low birth weight babies, preterm delivery, and infant mortality, as well as maternal adverse effects. This is just some statistics showing us that those patients that have increased prenatal care and early access to prenatal care have less pregnancy-related deaths. Unfortunately, the first trimester prenatal care initiation is low for Black, American Indian, Alaska Native, and Pacific Island women. So these are the populations we're targeting, really trying to get these patients in specifically as early as we can in a pregnancy to address their concerns, screen them for medical disorders, and get them the access that they need to have a healthy pregnancy and delivery. So how can we improve? Increasing the amount of providers we have and the amount of appointment availability. We have expanded that a lot since I've been here. I've been here only over about like a year and a half or so. We've hired more MFM specialists like myself. We're growing our department. We're increasing the access to consultations with MFMs like myself, access to ultrasound services, and especially for women that are like later in their prenatal care, didn't know they were pregnant, and now they're coming in with a lot of questions and a lot of maybe some boxes that were not checked in their healthcare previously. We're getting that done as soon as we can when they come into their pregnancy care. Okay, and community outreach with Lauren. Lauren will talk about that a little bit later. So taking time to educate patients to address their own health issues and learn why they're important, helping patients navigate the healthcare system. We have our social worker in our clinic here as well. We have nurses and medical staff that is very supportive, and they will reach out to patients that maybe don't show up to their appointments and ask what's going on, how can I help you better enable yourself to come to your appointments on time, or reschedule as needed. Like, we're trying to help patients not slip through the cracks, because the patients that do slip through the cracks have the highest rates of adverse outcomes. We're doing more telemedicine visits. Home visits is something we're thinking about doing in the future. Where this is a project I'm especially passionate about, helping patients to track their own blood sugars and blood pressure values, patients that were following for gestational diabetes or hypertension in pregnancy. There is a way to use Epic and the EMR to enable them to directly input their values into their own chart, so we can more easily access them, not only during their appointments, but between their appointments. And we're able to say, hey, you need more insulin, or you really need to come in for an evaluation. And follow through, like I mentioned, really capturing those patients that fall through the cracks. Okay, delivery hospital quality. So unfortunately, many studies have shown that the minority populations tend to deliver in lower quality, less safe hospitals than people in like a white population. And there's many studies that have addressed this, unfortunately. Hospitals with deliveries of more Black women had higher risk-adjusted severe maternal morbidity rates for both Black and white women at those hospitals. In New York City specifically, Black women are more likely to deliver in hospitals with higher risk-adjusted severe maternal morbidity. And this is just a graphic kind of discussing that. But as you can see, this red line here is non-Hispanic white deliveries, and a greater proportion of women deliver at hospitals on the left portion of this graphic, which is safer hospitals. The blue line is non-Hispanic Black patients delivering at, also at lower risk hospitals, but more of them delivering at higher risk hospitals. So fortunately, we do an excellent job here at Brooklyn Methodist to make sure we're holding the highest safety standards that we should be holding to, and we're in the New York Presbyterian enterprise. So I'm on several committees looking at, addressing protocols and safety checklists to make sure that in the delivery setting, we're standardizing care for not only all of our patients, regardless of their race, but standardizing care to make it just as good across every hospital in our enterprise. And we look at ACOG, which is the American College of Obstetrics and Gynecology, and Society of Maternal Fetal Medicine, to keep up to date with the latest evidence and literature to make sure that we are echoing what the statements of those societies are in our protocols and our checklists. We have patient safety nurses that have been, instituted since I've been here. We're doing more toolkits and simulations, and that is only on the rise. So, we're doing a good job of addressing things that are happening when they're not happening to the best extent. But the most important part of that is that we're changing the protocols, and we're getting nurses to buy in, and we're getting trainings to happen, and instituting things like insulin drips. And really, we're doing a good job, I think, of this, and it's only getting better. This is just another website. That's a good website as a source to go to look at maternal quality improvement toolkits. There's a Safe Motherhood Initiative by ACOG, which has several safety bundles, which like I said, New York Presbyterian has modeled several of our protocols off of these toolkits and bundles. And there's apps that can be downloaded, and early warning systems that we doing our best to really do that here at Brooklyn Methodist. Postpartum, super important part of prenatal care, actually I guess postnatal care. We often refer to it as the fourth trimester. This is where we're falling through the cracks with our patient care, not just us at Brooklyn Methodist, but in general across the United States. The no-show rate for postpartum visits is extremely high across the U.S. And ACOG has addressed this in their committee opinions and bulletins. So we're recommending a week to 2 weeks follow-up for patients with hypertensive disorders of pregnancy. We're sending them home with a blood pressure cuff, strict precautions, strict counseling. We're giving them a callback number to call in if they have questions. And we've seen many patients in the hospital presenting with elevated blood pressure after delivery and getting the care that they need, but we're really working hard to improve this and improve patient education. Patients with preeclampsia who delivered and had no cardiology follow-up had an increased risk of other disorders such as cardiovascular disease like stroke, hemorrhage. So this is important not only for like a pregnancy standpoint, but for the woman's life and the rest of her life and health. So when we see patients with preeclampsia in our hospitals, in our antepartum unit, we're addressing this, and so are our providers. We're saying, hey, this is an important issue for your pregnancy, but also for your life. And going forward, to be a healthy person, to take care of your future baby, your babies, and yourself, you really need to keep track of this after delivery, not just during pregnancy. Same thing with patients with gestational diabetes. They have an increased rate of developing type 2 diabetes. So every patient we counsel with diabetes is being told, you need to follow up with a primary care doctor and get screened for diabetes after pregnancy is over for the rest of your life, at least once per year. And then if they have another baby, they're at extra increased risk to have another pregnancy with diabetes. So we screen for those patients early in their next pregnancy. So, I work very closely in conjunction with our endocrinologist here. We have many, patients with diabetes that are either gestational or pre-gestational, on insulin, on medications, and we're doing better and better with keeping track of them. But the postpartum time period is still a gap, and we're working on improving that. Not just for us here, but everywhere. That's just one of these gaps. It's hard to get people to come in for visits. Unfortunately, lower income women have the lowest rates of postpartum visit attendance. They get lost to care, and then they end up pregnant. And a lot of times, whatever issues they had in their first pregnancy were not addressed. They didn't go back to their doctor. They didn't get their pap smear they're supposed to get, etc. And now they end up with a complication in another pregnancy. Okay, so how can we take action? So this is what ACOG has said. To optimize the health of women and infants, postpartum care should become an ongoing process rather than a single encounter, with services and support tailored to each woman's individual needs. So it's recommended that women have contact with their OBGYN or other provider within the first 3 weeks of postpartum. So we typically do a 2-week visit about that, sometimes a 1-week visit if there's a more concern about a blood pressure issue, and then again at 6 weeks postpartum. But really, it shouldn't end there. This should be an ongoing discussion. I try to encourage patients to follow up with their primary care doctor. I try to have them institute an appointment before they leave us at 6 weeks. Have your appointment set up with cardiology, with endocrinology, with internal medicine. Have it scheduled, because they're more likely to attend it if it's on their schedule than if they're given a phone number and walk away. Right. So kind of putting that into the language of like, when a patient delivers, it's not just, okay, you're going to see us 2 times. Yes, you're going to see us 2 times postpartum, but also this is an ongoing health assessment. You will need to take care of yourself in other ways and get your chronic medical conditions evaluated or screened for, even in healthy women, screened for these conditions on a yearly and annual basis at the very least. This is like a nice graphic of a postpartum team. We're, counting a lot of times on patients' friends and family that come to the appointments with them. We talk to them about warning signs like for depression, anxiety. We're trying to use doulas more and more in the outpatient setting and the inpatient setting to help patients feel like they're getting well-rounded postpartum care, not just you're a checkbox. Okay, you showed up to your visit. Check. See you in 6 weeks. Okay. So really doing anticipatory guidance with patients, talking about the postpartum visit while they're still pregnant, talking about breastfeeding and lactation and support while they're still pregnant can go a long way because, once you deliver, there's a lot of other things you're worried about, but it probably will make more sense to you to go to a postpartum visit or plan for a postpartum visit if you're like, yes, I've heard that before from my doctor or my midwife. They did tell me that's super important to follow up. So we're encouraging that and doing a pretty good job here in Brooklyn. Of course, we're still having no-shows and missed appointments, but addressing this before delivery and after delivery is something we're working towards. And I'm encouraging all of our residents here and the midwives and the attendings to talk about contraception, particularly in patients with multiple children at home or many medical problems. And maybe we're giving them homework to go home with, like check your blood pressure twice a day, take your medications for blood pressure, take your insulin, follow up with these doctors. It's probably in their best interest to at least have contraception discussed or implemented before they leave the hospital or their postpartum visit. I'm working with several residents actually to help institute this as more of a routine thing in the hospital that like we offer this for contraception. If you'd like to talk about this more, let us know. We can give you some materials to read and really educate them about their options. And of course, educating them about their higher lifetime risk of maternal cardiometabolic disease if they've had the pregnancy outcomes listed here, which are not super uncommon, especially in minority populations. Miscarriage, neonatal death, and stillbirth follow-up. These patients also need to be seen. And those are the ones that are even more lost to care because, they had an early miscarriage. They feel like, well, I'm not pregnant. I'm not going to go to my appointment. Not true. We should address why did this miscarriage happen? Were there any factors that could have been involved, like an uncontrolled medical disorder or a genetic issue? Should we refer you to genetic counseling? Same thing with like a stillbirth or a neonatal death. Patients are very obviously psychiatrically, mentally affected by these very awful, sad outcomes. We really need to make sure we're following up with these patients closely and getting them the care that they need. Okay. Okay, so in conclusion, preconception care, we need to continue to increase access to subspecialists, maternal-fetal medicine specialists, and to educate patients about why it's important to take care of themselves before pregnancy and seek the care that they need before pregnancy. And then during pregnancy, individualizing patient care, addressing barriers to care, following up with patients that are at higher risk of falling through the cracks, offering them alternative care models like telemedicine, helping them electronically deal with, you know, following through with their finger stick evaluations or their blood pressure evaluations, and really involving a whole care team, not just one specialist. Delivery care, we're instituting safety bundles and checklists, doing protocol adjustments as needed, simulating obstetric emergencies such as hemorrhage and sepsis and I guess obstetric morbidities. So those are more easily treatable things and things that are just like routine standard protocols. And we're doing that to address the ever being updated evidence that ACOG has provided us, and standardizing our practices across NYP in Brooklyn and everywhere else as well. And then for postpartum, super important to talk about postpartum visits before delivery even happens, talk about the importance of follow-up, managing their medical issues, and addressing contraception, which is super, super key. And we are doing all these things. We're addressing these things in Brooklyn. We have myself and Dr. Atala, who's the other high risk OBGYN here right now. He's also the vice chair of obstetrics and plays a big role in safety on labor and delivery and postpartum as well. We have postpartum safety nurses now, or safety nurse now, and we also have L&D safety specialists in play. And we are expanding our MFM division for at least a third person will be added, potentially a fourth person in the near future. So I guess I'll pause there and I'll hand it over to Lauren unless anyone has questions for me at this point right now.
I think we'll take on my slides and then we'll
Okay.
open it up to the floor.
Sure. Do you want me to click through them, I guess, since I have it on my screen?
Yeah, sure. I'll just say briefly, my name is, I introduced myself a little earlier, but some other folks have joined. My name is Lauren Amelino. I'm the Program Director of Community Affairs at New York Presbyterian. I cover both the Brooklyn Methodist campus in Park Slope, as well as our Lower Manhattan campus. You can go to the next slide.
Okay.
So, Dr. Grossman did a wonderful job talking about, health disparities when it comes to, women of color, women in general in New York City. And, the hospital is, what are we doing to address that? Dr. Grossman talked a lot about what's being done within the department, but in addition to that, there are a number of resources we put into play. During COVID, unfortunately, we had a very brief period where expectant persons had to birth alone, which was, happened in a lot of hospitals across New York City. And so we advocated to bring on doulas to provide that additional support if a support person wasn't available. And so any birthing patient can request to have a doula at New York Presbyterian Brooklyn Methodist. We're very proud of the doula program. Birthing doulas, we also have postpartum doulas, which I'll talk about in a little bit. But it's, when we talk about social determinants of health, it goes beyond a clinical condition, right? It goes beyond that to when we think about the social determinants of health, and doulas are really providing that emotional support and that sort of, they're there for patients beyond, clinical indications. They're there for their, well-being as well. Next slide. So I talked a little bit about postpartum doulas. This is a wonderful program that started at our Columbia campus, uptown in Washington Heights, where we link up with community-based organizations that train doulas. In Brooklyn, we actually link up with Caribbean Women's Health Association, which is, I believe, in your neighboring community board, not quite community board 14, but we work closely with Caribbean Women's Health Association to provide postpartum doulas. Dr. Grossman talked about the 4th trimester, and that time is crucial and critical, especially for pregnant persons who are high risk. That first week, 2 weeks, month after pregnancy, after birth, is really when people need, there are a lot of things that could come up. There are a lot of complications that could come up, especially if there are, pre-pregnancy complications. So the doulas are there to provide that extra level of support, and in multiple languages. I believe we have Haitian Creole speaking doulas as well as Spanish speaking doulas. And, Dr. Grossman also alluded to in-person home visits. During COVID, we were restricted to doing virtual visits, obviously, but home visits is one of the things that this program was built upon. So we're really thinking beyond the hospital stay and making sure that patients are getting the support they need, after they deliver as well. So this is super exciting. I've been at the hospital many, many years. I've been at the hospital going on 16 years now. And for the longest time, we've been working, we work with community organizations, and they're always asking me, you have a bus? You have a bus? You have a bus that comes out? And I said no for so many years. We finally have this amazing bus. And this is our baby bus that is designed to connect those folks who might be uninsured or undocumented, who are not having a way to access, the healthcare system. This is providing a way to sort of get them in, and anybody who's high risk, especially we find, as Dr. Grossman mentioned, people who are experiencing other issues in their lives, whether it's undocumented, uninsured, they have a lot of socioeconomic factors going on. Those are the people that are falling through the cracks, right? So these are the people that really need to be captured. And what the amazing thing about this mobile medical unit, it's going to be serving both Brooklyn and Queens, and it's going to be really getting to patients where they are instead of having them come to the hospital. And these are really addressing the patients who need to be connected the most. Next slide. In addition to the support provided by at the hospital and by the doulas, we also have this amazing breastfeeding and chest feeding support groups. We have virtual options, in-person options. There's a fabulous one, a group that began in Bed-Stuy in November of last year in collaboration with Babyphoria. These are all led by certified lactation consultants, most often internationally port certified lactation consultants. And I have to say, and I'm glad Dr. Grossman brought up that picture when we were at the baby shower at Medgar Evers College. Like, the folks in parent-child health are like amazing community champions, and they really, it goes beyond four walls of the hospital, and they really want to get out there and provide education and reach our patients where they're at. And it's a beautiful thing. And so this is an example of that. These are folks who are, more often than not volunteering their time outside of their normal work hours to run these groups. So I will provide more information about the groups in the chat. But I think there might be one more slide, a couple more slides actually.
Yeah.
So, and Dr. Grossman can probably speak to this a little bit better than I can, but you can see we have a whole host of gynecologic and obstetric services at New York Presbyterian Brooklyn Methodist Hospital. I'm not going to tick off all of these, but we're very fortunate to have Dr. Grossman and Dr. Attal on board for this high-risk pregnancy maternal fetal medicine specialist. We also have a very robust midwifery program at the hospital, which is really fabulous and amazing. We have a fabulous, neonatal intensive care unit that also has a patient family advisory council. So we're really committed to sort of improving and increasing and providing the best quality care at our hospital.
I just want to add in a quick thing while we're on this slide, in terms of complex family planning. So I'm an abortion provider here in Brooklyn, so I've been doing abortions for a variety of indications where we didn't previously have that availability here, and now we also have a family planning while Cornell faculty member coming twice a week. She comes on Thursday for family planning clinic and sees patients outpatient. And on Friday, she does OR cases here too. So we have also very excellent access to abortion care as well.
Yeah, and another thing that I wanted to mention too, thank you for that, Dr. Grossman. The other piece that you don't see reflected here, and I didn't include these in the slides, but when you look at our team, there are, we have a very large team of specialists at the hospital in maternal child health care, and they're from all diverse backgrounds. And that's the beauty of, of being in Brooklyn, right? We see a lot of diverse patients, but we also have diverse clinicians who our patients can identify with, and that's extremely important, especially when you're thinking through things like, you want somebody to take care of you that looks like you, that'll really understand the whole picture and what you faced as a patient, because they may have faced it themselves. Mm-hmm. Next slide. So here we have a list of all of our various practice locations that treat OB/GYN, OB and gynecologic patients. So you can see it goes beyond Park Slope. We have a number of different offices and practice locations, including one right there in Flatbush, 1910 Nostrand Avenue. We have downtown Brooklyn. We have one in Flatlands at 3417 Kings Highway, Bay Ridge. There's some midwifery locations, I think, in Williamsburg and even in Rockaway. So we really are across Brooklyn, and we're really trying to serve our patients and be as accessible as we can for our patients.
Oh, this is my references from before. Sorry, that was your last slide.
That's okay. And then so I'll have, like I said, I talked about a lot of stuff, so I'll put those resources in the chat, but I think we're gonna open it up for questions.
Hi, everybody. If you would like to ask questions, you can either drop them in the Q&A and then they'll come to me and I'm happy to read them out, or you can use the little toggle thing to put your hand up. And do you want me to do it, Florencia, or would you like to take people's questions?
You can take the questions. I just want to thank Dr. Grossman and Lauren for your presentation today. So you can, I'll turn it over to you to monitor because you can see the full screen. Or I should ask, my co-chair is there if she wants to do it, because last time she did it. Yvette Claire Jean she's available today, so we have more help. Hi, Yvette.
I'm happy to take care of it, but maybe I'll ask the chairs first. I mean, I would just also like to express it was a
yes.
wonderful presentation. If either of the chairs have any questions that they would like to raise from the presentation, and then we can do a general opening it up.
Yvette, do you have any questions? Well, I did have one, and I also, our co-chair, our chairperson, Joanne Brown is here. So if Joanne would like to say something, since Sean is not here today, we'd appreciate that as well. So Joanne.
I just want to thank Dr. Grossman, and I want to thank Lauren Avellino for being here today and giving us this amazing presentation and all of the information that we can share with our community members. So thank you again for being here and taking the time for Community Board 14 and our community.
Thank you. Thanks, Joanne. I wanted to ask, Dr. Grossman, you mentioned that the US, there are other countries that are doing, they have better health results concerning maternal morbidity. Are we studying their, what they're doing that's working as opposed to what's not working for us?
Yeah, that's a great question. I mean, there definitely has been a lot of investigation looking at places like the Netherlands, Sweden, other European countries. I think it's a multifactorial issue to look at, because health insurance is different, coverage for healthcare is different. Also, I should mention this, of course, we all know that our maternity leave policies, paternity leave policies are very different here than they are in Norway, whether I think there's a lot more support for people to be home and take care of their families and go their doctor's visits and whatnot, instead of saying, oh, I just delivered, I have 2 weeks off, 3 weeks off, then I have to go back to work. So, that is a difference. I don't know, within those countries, I'd have to look to see if there's the same minority race differences that there is here. I don't think the differences are as stark, you know what I mean, between rates of follow-up visits and rates of adverse outcomes in those countries. But it's hard. There's so many different factors, political factors, insurance coverage, all of that is so different elsewhere that it's hard to emulate those places. But obviously they're doing some things that we're not doing.
Thank you. Thank you. So, Yvette or Sarah, is there anyone were there any questions placed in the chat box?
Any questions yet, but I do have a question for Dr. Grossman. Thank you so much for your presentation. I was wondering, in terms of, you talked about all of the different practices that you have in place to assist women during their journeys, either from thinking about becoming pregnant, through pregnancy, through postpartum. What are some ways that in the event that something does go wrong with a pregnancy, how is it discussed and amongst the medical team? Is there like a system of psychological safety where members of the team feel comfortable to be able to say, this was the mistake that was made so that we can learn from it and move forward and not make the same mistake in an instance with another mother?
That's a great question. Of course, we have situations that happen in outpatient settings, inpatient settings. We have a system in place where we can also, like if someone's involved in a situation where like maybe a medication was delayed or something and there was some concern for a patient outcome, however severe it is or not severe, we have like a keep safe system in place where anyone anonymously, could be a nurse, could be medical assistant, could be a physician, doesn't matter, can log in and report that event, with the purpose of not like getting people in trouble, but so another committee, a safety separate committee, can go in and look at the chart and investigate and see, okay, what actually was documented, what happened, let's investigate this further. And then it's brought up at QA meetings, quality assessment meetings, which we have monthly. I've been involved in many of them, and we go over cases in detail. I can only speak to the OB/GYN department, of course, but I'm thinking similar things happen in other departments in our hospital. But definitely there's a much more now in the last 10 years or so, 5 years or so, the culture of like, let's talk about these things. Like something happened that's not right. Like, let's learn from it. Let's make a policy change. Let's address what happened. That's much more of the culture now versus like when I was in training, like 10 years ago, 12 years ago, like it was more like, oh, you're in trouble. We're going to go over this and present this case, and everyone's in trouble now. That's really not the goal here, and it hasn't been for a while. So I think we are doing a good job, and we have a system in place basically to discuss things that were not maybe done optimally. We're open with patients. I've been involved in many conversations with patients about what happened and what implications that can have for their pregnancy or for their baby. Oftentimes it's best to have those conversations with a team, like you mentioned, like a nurse, a doula, a patient's family member, like just to kind of give them full support and an understanding of what happened and how we're making, steps to improve things. That's a great question, though.
Thank you. Board member Elizabeth.
Hi, thank you so much for these presentations. Really informative. One thing that I kind of thought about when you had talked about it is just I'm curious what kind of efforts have been made to improve maternal health for overweight patients, especially since, I think we've seen a lot of data out there that maybe, it's difficult to change like an individual person's weight, and there's a lot of side effects to potentially medical interventions to it. And, there is a noted, there's been, especially through COVID and just, other things, become really aware of how some of it, or maybe potentially even a lot of healthcare towards women in larger bodies and people in larger bodies in general, is about how doctors interface with them and not necessarily the actual body composition. And I was just and I've heard before too that there's a lot of that often there aren't larger bodies in medical school training and so forth. And I was just wondering what parts of how this can affect the how that's being evaluated for maternal health, especially knowing that obesity is higher in high prevalence in underserved communities, which disproportionately affects people of color and so forth. Thank you so much.
That's a great question. We definitely have a higher rate of obese patients in our population here, not unique to Brooklyn Methodist, and Brooklyn and Queens and Manhattan. Like we have a higher rate of that, and that goes along with all those medical issues I talked about, right? Diabetes, cardiovascular health, hypertension. So we are trying to encourage women, like people that are seeing their OB/GYN for routine care, like pap smear, annual exam. Women are actually more likely to see their OB/GYNs routinely than they are to see their internal medicine specialist. I don't know exactly why that is. Maybe they feel more comfortable. I don't know. But we've reached out, like I have plenty of conversations about this with our general OBGYNs, not necessarily those that even deliver babies, but like the general people doing pap smears and gynecologic surgeries and whatnot to say, hey, you're seeing this woman for her woman exam, you're doing her pap smear, you're doing a uterus evaluation. Can you make sure we address her weight or her blood pressure or her diabetes? Ideally, send her to the specialist now, even like before pregnancy is even a thought. Just send them to get the care that they need, on a routine basis. So in other words, we're doing more referrals. We're doing more referrals to internal medicine, cardiology, nutrition. We have a nutritionist in our outpatient setting here and where I work in the ultrasound unit here. She sees pregnant and non-pregnant patients. So we're trying to get people to address their nutrition goals and concerns, ideally as early as possible in a pregnancy, or even not in pregnancy itself. There's more use of the injectable medications now for weight loss in obese patients. We support weight loss before pregnancy, ideally. Once people are pregnant, once they're in our care, we talk about we don't want you to be like aggressively losing weight in pregnancy. Just eat healthy, try to eat small meals several times per day, drink water, be like nutritionally healthy. But obviously, we're not going to talk to people about dieting in pregnancy. But overall, patients that do have like bariatric surgery, for example, and have lost 100 pounds or something, the rates of their outcomes in pregnancy and in their lives in general is lower, like risk of heart disease, hypertension, diabetes, severe sleep apnea, which causes several other issues related to the heart and the brain. All those rates are lower, including preterm delivery, miscarriage, all of that. If you go into a pregnancy in a lower normal BMI versus an obese BMI above 30, for example. So those are being addressed. I think there's still gaps in training, like you addressed. It's probably more of a focus now, if I had to guess, like than it was when I was in medical school, because it's being more addressed and transparent now. And we are addressing BMI at our visits and discussing that with patients, because it is a health epidemic, and it's a major contributor, not the only one, but is a major one to contribute to poor outcomes for moms and for women in general. So we're trying, we're doing the best that we can. There is, of course, gaps. Like if I refer to someone to a bariatric specialist or, an internal medicine specialist, it doesn't mean that they're necessarily going to go to that appointment. They may get the appointment and then they don't show up. And I'm trying to like chase that the next time that I see them. So it's not perfect, but
it sounds like it's still very weight loss focused and not necessarily focused at health on the best outcome at every existing size, which maybe there's some more work to be done there.
For sure, 100%. Yes, 100%. We have people delivering all different weights and sizes, and of course, the focus is not only on weight loss, but that's where my brain goes automatically, because that's what I'm counseling people about preconception as far as safety for pregnancy. But for sure, we have goals and things that we need to continue to address for patients of all different sizes in pregnancy, and just not just pregnancy. I keep focusing on that because that's my specialty, but of course outside of pregnancy as well.
Florencia? Florencia, you're muted.
Thank you. Sorry, something else popped up on my screen and there it goes again. Alrighty, thank you very much for that. And also, I just wanted to say, I do like that you do have the midwifery as well as the doulas, birthing as well as postpartum. I wasn't aware of the dangers postpartum. I like how serious it is. So this is really enlightening for me. I'm also glad that there are programs that will address those who've, miscarriage or had stillbirths, because it does affect. We've had folks in our church that have, been affected by that. And it does take a toll, not just on the person, but on families. So I'm glad that more families are involved. The programs are involving families as well. I just wanted to know, how involved are the doulas from pregnancy and after?
And I know Lauren can probably talk to this also, but I know that several patients ask about doulas when they come in for consults or for care. And some people like find their own private doula, like they pay someone that comes in there, it's like their doula. But, apart from that, we have doulas at the hospital in labor and delivery. I think around the clock, if I'm not mistaken, that really help support women through the labor process, the delivery process, and postpartum, but also we have a doula physically in our outpatient setting. I know in high risk clinic when I'm there, but also I think for routine prenatal care visits too, that they really check in with every patient after their visit. They're like, is there anything that you found confusing, or can I help with any, bridging the gaps of your understanding, or help you achieve any of the goals that the doctor mentioned to you, or the nurse practitioner mentioned to you, or the midwife mentioned to you. So we have them in the outpatient setting all the time. As far as my understanding, I see them all the time there. I see them in the hospital with our patients through their delivery and after delivery. And they work really well, I should mention, with the lactation consultants too, to support lactation needs and goals. But they're ever present, and people can choose to have them with them or not. Like, it's not something we're saying, oh, you have to have your doula. Like, it's totally up to the patient and what they're most comfortable with.
Okay, so they're effective in having better outcomes. Okay.
I think they're great. I'm always tell patients are like, should I have a doula? And I always tell them it really can't hurt. It can't hurt, honestly. They're super understanding and nice, and they support the medical team and the providers. Like, they're also a patient advocate at times too. Like, so for me, I'm all thumbs up about doulas, and the ones that I know here from New York Presbyterian, I think have been great in the inpatient and the outpatient setting. Yeah.
Thank you. Thank
Mhm.
you. Sarah?
Thank you. So I was wondering what the hospital does to connect folks. Also, I know there are programs like the Bridge program, which is like an unconditional cash transfer, and other kinds of like non-medical interventions to assist with maternal mortality and infant mortality. So are those things that you generally promote among your patients, or not so much?
Yeah, I think Lauren, are you there? Yeah, you might be able to speak just a little bit better than me.
Yeah, absolutely. So, we often talk about, we're here, the clinical teams are here to serve our patients within the four walls of the hospital, but there's so much that happens outside of the four walls of the hospital. And I think a lot of that is in working, we can't necessarily reach our patients where they live all of the time, or where they're at. So, one of the things, I talked about the baby unit that's going to be going out. There's a piece of that there'll be a community health worker on board, and they're really there to think through other programs and other services that they can connect patients to, other things that they can take advantage of, like the Bridge program. And similarly, the doulas with Caribbean Women's Health Association, we work closely with the CBOs to connect patients to other benefits that might be available to them outside of what the hospital can offer to them. So certainly those things are being considered. I think that we can probably do a better job and reach more patients, but those are things that we're building out for sure.
I know at the initial prenatal visits, there's a lot of material given to patients about various programs available to them, including the doula program and the Bridge program. I have seen a lot of like paper materials, at the prenatal visit initially. I think we're doing a pretty good job addressing these things. I think the follow-up could be a little better, like, hey, did you think about this program? Do you want me to contact someone for you? But, we do have a lot available.
And also, I was just thinking at our outpatient, the social worker in our outpatient department is amazing, and she
Yes.
really is very diligent about constantly updating the resources that are available and making sure patients know about them.
Yeah, Joan is excellent. She's very hands-on, and I know her very well, and she helps a lot of our patients. And I will specifically be like, hey, Joan, this patient wanted to speak with you last week. She had to run out for her to get her kid from school, but can you make sure to follow up? And she's like, it's on my list. I know, like, she's on top of it. So she's excellent too, and a great resource.
Thank you. I want to thank you. I really appreciate doctors who care as well, because we know that recently I've heard others talk about going to the doctor or having an emergency at the hospital and being turned away. That could have potentially caused them and to lose their baby, and so, it's just sad that because of economic status, or, the hospital that you're brought to is not equipped or don't have the doctors that have the right bedside manners, that, lives can be in danger. So it's good to know.
100%. And we do take transfers from different hospitals for very, in the community, people that are maybe like discharged really quickly from somewhere else. And I'm like, okay, well, we need to figure this out and have you admitted and, go through your records and get records sent. So we do have a fair amount of that. And it's often an access problem, access to the right places, and, getting to their doctor visits, and they don't go to their visits because they can't because of XYZ. Then they end up with a much bigger problem, and they end up with a hospital that's maybe less equipped. And then we see them, so we have a lot of that. Yeah, unfortunately.
Sorry to interrupt this wonderful conversation. Just doing a time check that it is 2:06.
Thanks, Joanne. Thank you. So I want to thank you, Dr. Grossman. I want to thank you also,
Thank you.
Lauren, for this presentation. Well received, lots of information. There were things I have given birth to 3 children. Thank God for the doctors that I had. And I'm thinking, as you were presenting, if I knew then some of the things you talked about, I probably wouldn't even. But, still, I had great doctors, so I'm glad my kids are okay, and I fared well as well. So thank you. I'll turn it over to my co-chair, Miss Yvette Claire Jean. Thank you.
Thank you,
So much.
Dr. Grossman and Ms. Avellino, for being with us today and presenting on maternal health disparities as part of our health and wellness lunch and learn. We really appreciate all of the information you shared. And we want to say a special thanks to everyone who joined us over the past 5 weeks for our very informative sessions. If you missed any of the sessions, they can be found on CB14 Brooklyn's website. The recordings as well as the presentation materials. Thank you especially to the staff of CB14 for helping organize this lunch and learn and for all of your support. And we hope that all of the information that's been shared over the last 5 weeks will help you, your family, your community members in taking care of themselves and prioritizing their health and wellness. So thank you so much, everyone. Have a wonderful afternoon.
Thank you so much.
Take care.
Thank you.
Thanks, Joanne. Thanks, everyone.